صباح الخير. النهارده ان شاء الله هنبدأ ب topics new topics في ال updates in diabetes management and comorbidities with the oral anti-hyperglycemic therapy by Professor Dario Rahelic.
Good morning, ladies and gentlemen. I believe that it's not too early, but I'll try to be on time to speak about oral anti-hyperglycemic therapy. Although it's a pretty wide thematic, I'll try to be on time. These are my disclosures. So, our understanding about pathophysiology of type 2 diabetes approximately 20 years ago was completely different than it's right now. Previously we thought the main problem is in increased hepatic glucose production and decreased glucose uptake due to insulin resistance and also impaired insulin secretion. Today we know that even energy homeostasis and the complexity of glucose control is much more complex than we thought, and also it includes visceral fat cells, brain, gastrointestinal tract, but also alpha and beta cells. We know that pancreatic islet function decreases over time, causing disease progression, and you can see it here that even several years before onset of the type 2 diabetes, we do have inadequate beta cell function. We have postprandial hyperglycemia and also fasting plasma hyperglycemia. Previously we thought that even insulin resistance is the highest in the onset of the type 2 diabetes. Today we know it can be even higher and more announced later on. But pathophysiology of type 2 diabetes is much more complex than just insulin resistance, beta cell failure. Today we know that it's important to emphasize the importance of alpha cell failure, also gastrointestinal or incretin defect, enhanced glucose reabsorption, altered fat metabolism, and also the role of CNS. The pathogenesis of type 2 diabetes is much more complex than we thought 20 years ago. But also, yesterday I mentioned in my workshop, I mentioned that beta cell function also deteriorates over time. And we know that in the time of onset of type 2 diabetes, more than 50 to even 70% of beta cells are damaged. Their function or they are damaged as a cells. Of course, genetics are important, and also epigenetics is maybe even more important. Today we know that more than 60 genetic losses are associated with type 2 diabetes, and we know that the epigenetics plays a very important role in onset of type 2 diabetes. There is evidence that several external factors can modify gene expression and gene function epigenetically, both positively or negatively. So when we talk about beta cell loss, we can speak about beta cell death or via apoptosis, but also we have to speak about the beta cell dysfunction and beta cell dedifferentiation. From that perspective, I will just briefly go what I mentioned yesterday in the workshop. Previously we thought that normal beta cell under pathological consistencies goes to death via apoptosis or programmed cell death. But today we know that majority of beta cell will be dedifferentiated, programmed, and it means that it will lose their ability to produce insulin, but will produce glucagon, somatostatin, the hormones which act completely opposite than insulin. From that perspective, we know that triggers of a beta cell failure are glucotoxicity, also lipotoxicity, islet amyloid polypeptide, cytokines. And we know that there is a possibility then when type 2 diabetes started that we can modify disease. And over time, glycemic control deteriorates, and we have lots of different drugs which we can use even in IGT, but also after onset of type 2 diabetes. Major targeted sites of oral anti-hyperglycemic therapy are mentioned here. Unfortunately, we don't have time to go through all of them because many of them are at the market for more than 50 years. So we will just mention new therapeutic options. We do know that despite many modern treatments and modern oral anti-hyperglycemic therapy for type 2 diabetes, metformin is still a gold standard for treatment. But when we choose a therapy after metformin, we know that all those drugs have different efficacy regarding HbA1c lowering potency, but also risk of hypoglycemia, risk of weight gain, and also major side effects. When choosing a treatment for type 2 diabetes, we have to balance between glycemic control on the one side and also side effects and also hypoglycemia and weight gain on another. People with diabetes are afraid of hypoglycemia because of they feel very bad within the episode of hypoglycemia, but we as physicians are even afraid even more because of all consequences which hypoglycemia can get. Not just cardiovascular dysfunction, not just risk of convulsions, but also decreased quality of life, mortality, and also costs. When we talk about novel oral anti-hyperglycemic therapy, we will mention two classes of drugs: incretin-based or DPP-4 inhibitors, and also we will mention SGLT2 inhibitors. We know that GLP-1 as a hormone is important in regulation of appetite, food intake, and also beta cell function, alpha cell and beta cell function. DPP-4 inhibitors lead to increase in a range of hormones and peptides. You can see it here. Unfortunately, we don't know what does it mean. DPP-4 inhibition can cause increased levels of many different substances and many different hormones, and we don't know its meaning. But what is important for us as clinicians is their safety, especially their safety regarding cardiovascular trials, which are pretty fashionable right now. And there are 3 clinical trials, cardiovascular outcome trials with DPP-4 inhibitors. You know them, it's SAVOR or SAVOR-TIMI, EXAMINE and TECOS trial. And those trials were completely different in their stratification. A number of patients examined had involved more than 5,000 people with diabetes, and SAVOR over 16,000. So you can see it here that all 3 of them, sitagliptin, alogliptin, and saxagliptin, were safe regarding 3-point MACE. So their cardiovascular safety was proven. But you also remember that in SAVOR-TIMI there was increased risk for hospitalization due to heart failure, and it was statistically significant. And also there was a signal in alogliptin study, in the EXAMINE study. We can argue it was a high-risk population within 3 months of myocardial infarction, but still they had a higher risk of hospitalization and due to heart failure. On the other side, also one post-hoc analysis in EXAMINE trial also found an increased heart failure in patients having no history of heart failure at the baseline. The another component is vildagliptin. Vildagliptin has few studies, but they don't have real cardiovascular outcome trial studies. So you can see it here also in VIVID trial. They found increased left ventricular and diastolic volume, what can be the reason of or possible reason to increase risk of heart failure as well. But we can ask ourselves, could be a heart failure a potential adverse events of DPP-4 inhibitors? And that was the reason why the heart failure was one of the outcome in all those clinical trials which were followed. And 2 years ago, TICOS trial was announced in ADA meeting in Boston, and in DPP, in all those trials, and TICOS trial confirmed that there was no increased risk for heart failure in sitagliptin, or group of people with diabetes treated with sitagliptin, in comparison to placebo plus standard diabetic therapy. So that was the reason why even guidelines has changed, and in guidelines you can see that they are pretty the same in efficacy, in their effect on weight, also side effects, but they are different due to different and possible risk of saxagliptin and allogliptin to increase the heart failure risk. On the other side, we have completely new class of drugs. The newest one is SGL2 inhibitors. So you know that SGL2 cotransporters belongs to a family of sodium glucose cotransporters which are located in various tissue. And you can see it here that SGLT1 and SGL2 cotransporters are located in many different tissues within our body. And we know that the main expression of SGL2 is in kidney, and we know for that because new class of drugs just increased our awareness of importance of kidney in glucoregulation. The primary site of glucose reabsorption in the kidney is in the first segment of proximal tuberous, and you can see it here. And there is SGL2-1 and SGL2 cotransporters, and SGL2 is responsible for more than 90% of glucose reabsorption. On the other side, also the efficacy of SGL2 inhibitors depends on glucose value, or plasma glucose, and also is independent of insulin secretion or sensitivity. When we look about SGL2 class overview, you can see it here that dapagliflozin was the first one which was introduced and registered by ADA 2012. And after that, we had lots of different SGL2 inhibitors which were approached to the market. And dapagliflozin was the first one, 2012, FDA approved dapagliflozin. And in Europe, it was approved 2014. In Europe now we have empagliflozin, canagliflozin, and dapagliflozin. But also there are many other SGL2 inhibitors all over the world. Especially in Japan, there is epagliflozin, first SGL2 inhibitors approved in Japan, 2014. But also, you can see it here, Tofo, Luzeo, ertugliflozin, sotagliflozin, all of them are already are approached to the market or approved, or will be approved very soon. The last one is ertugliflozin, which will probably be registered within 1 year, or 1 year and a half. When we look at meta-analysis of their safety and their efficacy, we can see that their potency for HbA1 lowering is between 0.6 to 0.8% of HbA1c. They can decrease body weight for approximately 2 to 4 kilos, and they can decrease blood pressure for 3 to 6 millimeters of mercury. The surprise was announced 2 years ago when the results of EMPA-REG outcome trial was presented. And just to mention and to remember you that EMPA-REG outcome trial involved or include more than 7,000 people who were treated with empagliflozin with 10 milligrams in dosage of 10 milligrams, 25 milligrams compared to placebo once daily. And just briefly to mention the results, time to death from cardiovascular causes, non-fatal myocardial infarction and non-fatal stroke was the primary 3-point outcome, and you can see it here significantly, and it was p-value was 0.04 for superiority, and for us as a clinicians, diabetologists, it was surprise because it was for the very first time we realized that some drug for treatment of type 2 diabetes can be even protective in cardiovascular disease, for cardiovascular disease. On the other side, you can see it here, 3-point MACE, but also the beneficial effect on cardiovascular death reduction, non-fatal myocardial, and slight increase on non-fatal stroke. But also, there was a significant reduction in death from any cause. On the other side, recently was published CANVAS trial with canagliflozin, and canagliflozin include more than 10,000 people with diabetes, and those participants were treated by canagliflozin in 2 dosage, 100 and 300, compared to placebo. And you can see the primary MACE outcome. It was for non-inferiority and for superiority. So canagliflozin showed the beneficial effect in reduction of 3-point MACE, but also in myocardial infarction rate. Stroke component was also reduced. There was reduction in stroke and hospitalization due to heart failure, and cardiovascular death or hospitalization due to heart failure as well. All-cause mortality, it was pretty similar than in comparison to empagliflozin trial or EMPA-REG trial. In summary, you can see here that all primary cardiovascular outcome and also components of primary cardiovascular outcome were on left side, so in favor to canagliflozin. We are still waiting for DECLARE trial, the results of DECLARE trial of dapagliflozin versus placebo on cardiovascular events. So it's a little bit different than other trials, because in dapagliflozin, in the DECLARE trial, it will be much more people with only multiple risk, not so many people who are already had myocardial infarction or some other cardiovascular events. So more than 17,000 people are already recruited, and they are treated by placebo or dapagliflozin in 10 milligrams. And the estimated completion is 2019. But also, we have real world data which confirm cardiovascular benefit of SGLT2 inhibitors in diabetic patients. There are many meta-analyses which show that for example, dapagliflozin cardiovascular meta-analysis showed no increase in cardiovascular risk, as you can see it here. Hospitalization for heart failure, majority of those people were treated by dapagliflozin, but also some of them with EMPA and canagliflozin. All-cause death as well, and heart failure or all-cause death was also in favor to SGLT2 inhibitors. Meta-analysis also showed that SGLT2 inhibitors can increase the risk of urinary tract infections, but it wasn't so significant to stop the treatment. All of them, no matter DAPA, CANA, epagliflozin, or some other. But we have to be careful, of course, with that class of drugs, because there are some issues regarding SGLT2 inhibitors, and there are several issues which we have to emphasize. One is decreased bone mineral density and increased risk for osteoporotic fractures, which was announced as awareness from FDA for canagliflozin. It seems that DAPA and empagliflozin are not in the same category for now. Also, increased risk of bone fracture, as I said, but also increased risk for DKA. So it's normoglycemic or almost normoglycemic DKA. So it's very important to emphasize that because previously we were not used that somebody who has glucose, for example, 13 milligrams per liter can have DKA as well. So those people are at higher risk, but sub-analysis showed that majority of those DKA cases were in people who were treated as type 2 diabetic patients and they were type 1, and also with people who had very low beta cell function. On the other side, it seems that SGL2 inhibitors can even improve renal function, and you know that usually we are not using SGL2 inhibitors in impaired significantly or severe renal function, but it seems that empagliflozin, dapagliflozin and canagliflozin can even slow the progression of renal dysfunction in people with type 2 diabetes. But also we have to be careful because there were several cases of acute renal dysfunction or failure and also acute kidney injury. But it happened only also with canagliflozin, with empagliflozin and dapagliflozin it wasn't like that. And the final awareness from an announcement from FDA was for canagliflozin, an increased risk of 2 amputation, so we have to be careful regarding that. Also, there was one question regarding bladder cancer in type 2 diabetic patients with some other drugs, and also because of high urine concentration of glucose, there were a few questions regarding bladder cancer incidence, and it seems that all evidence which we have does not suggest a causal relationship between dapagliflozin, empagliflozin, canagliflozin and bladder cancer. So when we look at the future, we don't know. Now we have 2 new class of drugs. Even DPP-4 inhibitors as oral anti-hyperglycemic therapy are not new anymore. SGL2 inhibitors were a new class of drugs a few years ago. Now we are expecting new class of drugs. Now even semaglutide is in phase 3 clinical trial as an oral component of GLP-1 receptor agonist. There are many other molecules. So, but at the end we have to ask ourselves, we have to use the best what we have right now, but also we have to consider what is the future of treatment of type 2 diabetes. Probably, as I mentioned, that beta cell dysfunction doesn't mean just beta cell loss due to beta cell death, but also due to beta cell differentiation. Probably the redifferentiation would be the road to the future therapy of type 2 diabetes, and some drugs could have that potential role, especially GLP-1 receptor agonists. But at the end we have to emphasize the importance of genetics, the importance of epigenetics, the importance of environment, and also our habits. But no matter about interaction of genotype with environment to cause our phenotype, but phenotype, interaction with environment, competition, selection, evolution, we have completely new population. And now unfortunately we have a new population of people with diabetes worldwide. 426 million people with diabetes worldwide. So we have to prevent disease for better treatment. But also, when we treat our patients, no matter if we are using pharmacological or non-pharmacological treatment, we have to emphasize the importance, the quality of life, because this is our goal, to have old people with diabetes, but without complications, and with her first cigarette in her life, because of risk of osteoporosis, of course. And for the end, I would like to take opportunity to send the greetings from my country. I'm proud to be a Croat, so I like to show pictures from Croatia. I would like to send greetings from our capital, city of Zagreb, but also from this small country in the middle of the Europe, in the shape of the bird, as you can see, close to Italy and close to Austria and other Central European countries. But also, I would like to send you greetings from my country, which is country of 1185 islands, and one special island in the shape of the heart, which is very popular approximately in mid-February because of Valentine's Day. Country which is proud on its history, and country which is proud for football team. We are pretty good in football, and hopefully we will show our best in future contents. But also, it's a country which is a homeland of necktie. Whenever you will wear a necktie, just remember the homeland of necktie is Croatia. So thank you very much, and for the end I would like to invite you for our conference. And for the end, I would like to invite you for our diabetes conference, which will hold in May next year, and also we will have diabetes and nutrition study group of EASD, which will held in June next year. So you are more than welcome to visit country which is homeland of necktie and which is country of 1185 islands. Thank you very much.
Thank you very much, Dr. Dario, and it's very nice to have you usual in Egypt as usual. This is your second time, and it won't be the last time for sure.
Thank you very much for your kind invitation, and it's my pleasure to be in your beautiful country.
Is there any question or comment, please? Yes, doctor, please.
Sorry, can you wait for a microphone, please?
What about the use of SGLT2 inhibitors in type 1 diabetes and the risk of DKA? Is it safe or not? In type 1.
I didn't understand you, sorry. SGLT2 inhibitors in type 1.
Type 1.
Yeah, that's a tricky question, of course. From pathophysiological point of view, we could say why not, because you are not targeting beta cell function, so why not to use? But the problem, there are several issues regarding type 1 diabetes, because it seems that SGLT2 inhibitors can increase the glucagon concentration, and that's counterproductive for type 1 diabetic patients. So that was the reason, one of explanations why people with type 1 diabetes had more frequent DKA, and even in type 2 diabetic patients with low beta cell function. But there are many other explanations, but according to SPC, no, it's not allowed to use SGLT2 inhibitors in type 1 diabetic patients. Yes, please. In microalbuminuria. Yeah, it seems. So when we are trying to assess the function, kidney function, we usually use two markers: creatine albumin ratio, or just the creatine and glomerular filtration, which can be estimated with several formulas. And also we are trying to see what's going on with albuminuria or even proteinuria, because they are completely different. This is glomerular and this is tubular disease. So from that perspective, it seems that SGLT2 inhibitors are safe in people with albuminuria, no matter micro or macro albuminuria, because it seems that SGLT2 inhibitors can even decrease the range of albuminuria within 1 or 2 years after introduce of SGLT2 inhibitors. Yes, please.
Use of sodium glucose inhibitors as monotherapy situation. We could use it as monotherapy.
As a monotherapy?
Yes.
Yeah.
It is approved from Food and Administration drug.
Well, the problem is, of course, we always have the same problem. Is all those novel treatment appropriate for as a monotherapy. Now we have very clear evidence that SGLT2 inhibitors, empagliflozin and canagliflozin for now, but even dapagliflozin with CVD real trials, all those proofs could ask, we can ask ourselves, should I use SGLT2 inhibitors instead of metformin in people with after myocardial infarction? Also, as I mentioned, all those clinical trials, CVO3 trials, which right now we have, all of them were as a secondary prevention, not primary prevention. And we have only 30% of people with diabetes who already have myocardial infarction or some other CV equivalent. On the other side, we don't know, will it work as a primary prevention? So I would say that metformin will stay a gold standard for now because of pathophysiology of type 2 diabetes. And as a second line, it can be as a second line like in combo therapy together with metformin. It's not allowed in gestational diabetes. Yes, please.
I want to ask about vildagliptin as a molecule. It's widely used in Egypt, but I know it is not used in America and has no FDA approval and has no cardiovascular safety. Is it used in Europe, and what about cardiovascular safety?
Yeah. It's always a question in pre-diabetes and also in diabetes, which drug should we use? For example, metformin in my country is not registered for, and it's not reimbursed. It's better to say it's not reimbursed for prevention or from pre-diabetes or in treatment of pre-diabetes, metformin. But also all other drugs they don't have any studies about treatment of pre-diabetes. Maybe it will be, I know that there are 2 clinical trials right now which are trying to use SGLT2 inhibitors in healthy people, so just to prevent cardiovascular disease. So we need more clinical trials to know what is the real answer to your question. But metformin could be useful, and I usually recommend to people with pre-diabetes, but unfortunately they have to pay by themselves. And SGLT2 inhibitors, we don't know what would happen in slightly higher glucose value. So in that case, we don't know would it be useful or not.
I ask about vildagliptin.
Sorry?
Vildagliptin.
Beta? Oh, vildagliptin, sorry. Well, for vildagliptin, we have another problem. As you know, it's not allowed or it's not registered in USA because they didn't perform CVOT trial. So from that perspective, they focus themselves only to Europe. They do have some equivalents of CVOT trials, but it's not the real CVOT trial. I mentioned just VIVID trial, and they also published several meta-analyses with vildagliptin as a real-world data, and it seems that vildagliptin not increase the risk of heart failure, but we don't have the real proper CVOT trial like with empagliflozin, dapagliflozin, or canagliflozin. So from that perspective, I can say that only according to data which were published, and it was just meta-analysis, there was no signal for high risk of heart failure with vildagliptin. And also you know that vildagliptin right now has even generics variant, and it will change completely probably the situation within the Europe.
Thank you, Professor Dario.
Shukran.
And now Professor Stewart from UK, and she's going to talk about diabetes and pregnancy. Thank you.
So hi everybody, nice to meet you. My name's Zoe and I work in Cambridge in the UK. So thank you so much for the opportunity to talk about my favourite topic that is often neglected, which is diabetes in pregnancy. It's a large topic and we've only got half an hour, but if it's okay with you, I'll talk a little bit about gestational diabetes and then move on to talking just very briefly about type 1 and type 2 diabetes as well. So as we know, diabetes is the most common condition affecting pregnancy and has a very high prevalence in this region, this part of the world. But we know that the large majority of pregnancies affected by diabetes have gestational diabetes. So I'll briefly talk about the screening, diagnosis, management, and follow-up. We know that maternal risks, there are a number of maternal risks associated with having gestational diabetes in pregnancy, higher rates of preeclampsia, delivering babies earlier and via caesarean section, and probably the biggest, most important thing of all for the mothers is that there's a much higher risk of developing type 2 diabetes later in life and at a much earlier stage than the general type 2 population. In terms of infants, we know that gestational diabetes also carries a number of risks, both in the short term and later in life. So around the time of delivery, we see higher rates of macrosomia, or large for gestational age, rates of shoulder dystocia and Erb's palsy, higher rates of needing intervention after delivery, particularly for low blood sugars or hypoglycemia. And then increasingly, we're also understanding the impacts that diabetes in pregnancy has on these children for the rest of their lives. So we see higher rates of childhood obesity, but also later in life of metabolic disease, obesity, and type 2 diabetes. We also know that from the big HARPO study of over 25,000 women, that the rates of these adverse outcomes are proportional with the level of dysglycemia. So necessarily then, any cutoffs that we choose to diagnose gestational diabetes are arbitrary. We know that it's a continuum of risk, and so we have to make a decision at some point about where to call it abnormal and where to call it normal. There are a range of different risk factors for gestational diabetes, as you know, and they're quite similar to the risk factors for type 2 diabetes, particularly high BMI, previous large infants or previous gestational diabetes, a family history of type 2 diabetes, ethnicity, which is basically anything other than white, polycystic ovaries, infertility, or having required assisted reproductive services. And again, as you know, there's a lot of controversy surrounding the best screening protocols. So we have these debates all the time and on an ongoing basis about whether it should be universal screening, that is, we screen every pregnant woman as we do in our centre, or risk factor screening, where we use these risk factors that I just mentioned to decide which women should have screening. But we know that that risk factor screening does mean that about 50% of women won't be diagnosed with gestational diabetes because they don't actually have any risk factor at all. And the correct answer for these is probably different in different settings depending on the prevalence of the area. We can then talk about whether we should have 1 or 2 stage screening, whether we use a glucose tolerance test, a glucose challenge test, or even an HbA1c or fasting blood glucose, and whether this screening should be done at the first visit at booking or at 24 to 28 weeks, or perhaps a combination of the two. The most widely adopted criteria around the world are also those that are the most evidence-based, which are the IADPSG criteria for gestational diabetes. And these criteria are based on the HARPO data that I showed those graphs from. So the idea is that at a 1.75 relative risk of developing complications, we call those values abnormal. And those values turn out to be a fasting of 5.1, a 1-hour value of 10, and a 2-hour value of 8.5 millimoles per litre. There's also criteria there for diagnosing overt diabetes in pregnancy, and the implications of that are not particularly clear. In most cases, it would be managed relatively similarly during pregnancy, but it might be a little bit of a flag that this person might require some extra investigation to make sure that they didn't have pre-existing diabetes. As I mentioned, these criteria are based on a relative risk, so they're evidence-based, unlike most of the other proposed criteria. But the implications of introducing these criteria globally vary quite substantially. In my home country, in Australia, we know that the prevalence would jump from about 10% to about 13%, which is not so bad in terms of the impact on the health service. But in countries like Vietnam, you potentially quadruple the rates of gestational diabetes, and that has quite significant implications for the healthcare service. So it's important that we think carefully about which criteria we're going to adopt and how, in terms of making sure that we're able to give women that we've told are at high risk in their pregnancy a fair go at making sure that they can reduce their risks of complications. In the UK, there were separate criteria again introduced, which have a fasting of 5.6 and a 2-hour value of 7.8. These values were based on a combination of the data that's available, but also on health economics or costing, so they're relevant specifically for the UK context, and decided in terms of what the UK can afford to treat, rather than in terms of, as the IADPSG guidelines that are on risk of complications. As I mentioned, they're the first criteria that are derived from evidence from pregnant women themselves, but at the moment we don't have sufficient evidence about the cost effectiveness of implementing these criteria, particularly in different settings. We know that having one abnormal value, unlike some of the previous criteria where 2 abnormal values were required, may result in overdiagnosis and does mean a significant impact in terms of the number of women diagnosed for most places around the world. But it's not an arbitrary number in terms of that increase. It's not saying we're overdiagnosing most people, because we know from the HARPO study that these women are at risk. And again, yeah, it's true that a fasting test, and particularly having 3 tests for a glucose tolerance test, may not be feasible in some settings. And then we move on to talking about whether it's even worth diagnosing, whether treatment can make a difference. So we know from the Crowther study in 2005, A-Choice study, that treatment of relatively severe gestational diabetes is effective and reduces the rates of severe perinatal complications, so death, fracture, nerve palsy, and shoulder dystocia. But what about the more mild forms of gestational diabetes, where the debate comes in about screening and about the different thresholds? Well, we also know that treatment of mild to moderate gestational diabetes is effective. It had, in this study, the London trial, it had less of an effect in terms of the primary outcomes of death and the very severe outcomes, but there was a significant improvement in terms of reduction of rates of caesarean sections, of preeclampsia and pregnancy-induced hypertension, maternal weight gain, and a reduction in terms of rates of macrosomia and large for gestational age babies as well. In our own data in Cambridge, we're very lucky that we have a birth cohort study, the Cambridge Baby Growth Study, so we're able to look at the impact of different criteria and different management of gestational diabetes on infant birth outcomes within our own context. And what we found is that after HARPO, after the big study was conducted, we took a more aggressive approach to both the diagnosis of gestational diabetes, but also the management. The current guidelines that we use are a modified version of the IADPSG guidelines, close enough. The difference is in the fasting, but the take-home message is that they're tighter than what we had before with a fasting that went up to 6.1. So we're taking a more aggressive approach both to screening but also to treatment. The NICE guidelines suggest selective screening. The old NICE guidelines had a very high fasting value, which we didn't use in our centre. So if we look at the comparison here, we've got the control population, which is the general obstetric population in our unit, and then we've got the recent gestational diabetes cohort, that is the ones where we've been more aggressive in terms of diagnosis and treatment, and then the historical cohort where we were less aggressive. And unsurprisingly, the same as the rest of the world, our recent cohort is more overweight than the historical cohort. And their glucose disturbance, despite the criteria actually being lower, is actually more severe. So they have a higher glucose than the women did, say, 10 years ago. But what we did find is that with a more aggressive treatment regime and taking this condition seriously, we were actually able to reduce the birth weight in the current cohort to equivalent to the control group. So while the historic gestational diabetes infants had a higher birth weight than the cohort, the modern day ones, the ones using our current criteria, don't. So it shows really that this difference in terms of the treatment does make a difference. We're able to completely get rid of the risk in terms of infant outcomes by aggressively treating gestational diabetes. And this graph shows it here in terms of birth weight, but we can show it also in terms of skin fold, where actually the recent cohort has a lower skin fold than even the control group, and much less so than the historical gestational diabetes cohort. And so as soon as the woman delivers and the baby is born, and hopefully we've done our best job, and we're actually pretty good at doing that in our centre, but also around the world now, management of gestational diabetes has improved quite a lot. So as soon as the delivery happens, then the focus really needs to shift in terms of reducing diabetes risk and metabolic risk for the mother. We know that these women have a 40% risk of developing gestational diabetes again in their second and 60% in their third pregnancies, and up to a 70% risk of progression to type 2 diabetes within 5 to 10 years, which is exceptionally high given that this is a young cohort of women, and we're diagnosing them then with a chronic condition that will affect them for the rest of their lives. Among women with type 2 diabetes, we know about a third of them had gestational diabetes, so we had a warning there before they were diagnosed with type 2, and an ability to intervene and try and reduce or at least prolong the time into diagnosis of type 2 diabetes. One of the biggest predictors in terms of whether women do go on to develop type 2 diabetes is their weight. So we know that women who are at high BMI and who gain more during pregnancy, or who fail to lose weight after they have their baby, are at the highest risk. So it's important to be aggressive in terms of interventions aimed at gestational weight gain in pregnancy, but also in terms of losing the weight again postpartum. So women who gained more weight in pregnancy retained 3 more kilos than their counterparts even at 15 years after the baby. So it's really important during pregnancy to have a higher focus on weight. And we know as well that every increase of 1 kilogram in pre-pregnancy weight increases the risk of type 2 diabetes by 40%. So there are a range of different ways that we can reduce that risk. I'll talk briefly about metformin because people are often quite curious about my views on metformin. It seems like it's a logical option in pregnancy because we don't need to give injections, and it's very effective outside of pregnancy, but it does cross the placenta. It's often more acceptable to women than insulin, again, because it's oral. About 50% of the women who go on metformin will subsequently require insulin as well. And perhaps it's associated with some improved clinical outcomes, maybe lower rates of preterm delivery, weight gain in pregnancy, which would be great if it was true, cesarean sections, and possibly neonatal hypoglycemia as well. So the outcomes overall seem similar or maybe slightly improved, but it does cross the placenta, and we don't have good long-term data in terms of the infant follow-up. So up to 2 years, it looks like there are no adverse outcomes for the offspring, but there is a difference in terms of fat distribution, so it does have an impact on the babies. So there's less visceral fat and more subcutaneous fat on the infants of women treated with metformin, and very soon there'll be more data about these infants at about 7 years, so hopefully we'll have a little bit more information. Particularly, there's some hint maybe that it will have some impact on cardiovascular adaptations in the offspring. In terms of preventing type 2 diabetes, we know that diet and lifestyle interventions and metformin are equally effective in women who've had gestational diabetes, and both in terms of weight loss postpartum, but also preventing type 2 diabetes. The other thing that is incredibly beneficial in terms of reducing risk of type 2 diabetes is breastfeeding. So we know that if women can breastfeed for 3 months exclusively, then their risk of type 2 diabetes is halved within the next 10 years. So that's a key message that we're using as well, to try and get women to breastfeed as much as possible after delivery. So in terms of gestational diabetes, we know that there's ongoing controversy around screening and diagnostic criteria. The treatment reduces the risk of serious complications in women with severe glycemic disturbance and reduces the risk of those less severe adverse outcomes in women with mild hyperglycemia. So it's still worth doing. We can reduce risks roughly to the same as the background obstetric population. Both lifestyle interventions, including encouraging breastfeeding and metformin, reduce the risk of type 2 diabetes by about half. So it's incredibly important that we develop good programs in terms of keeping these women healthy for as long as we possibly can after delivery. I'll move on to talking now about type 1 and type 2 diabetes very briefly, and particularly type 1 diabetes and the use of technology is my main area of interest, so I'll touch on that just briefly. So we know that the only predictor of adverse outcomes, or the only consistent predictor of adverse outcomes in women with pre-existing diabetes, is the first trimester HbA1c. So the level of glycemic control really around the time of conception. And often we also know, that the really severe adverse outcomes, congenital anomalies, are predetermined often before these women even know that they're pregnant. So the message here is that pre-pregnancy care is really what's incredibly important if we want to have an impact in terms of improving outcomes for these women and their babies. So our centre conducted a study of pre-pregnancy care in the region and delivered an intervention. I'll talk briefly about what that includes in a minute. But what you can see is that, unsurprisingly, the intervention worked. So there was a better HbA1c pre-pregnancy in those women who'd had the program compared to those who hadn't. But what was interesting is that those who had not had the program, they did improve to almost the same degree across the course of their pregnancy. So we know that with hard work, we can get women much better as soon as they come and tell us they're pregnant, but they never quite reached the same level. So admittedly, it's only a small difference in HbA1c, but actually there's still a difference, even right at the end of their pregnancy, with our best efforts once they became pregnant. And so it's incredibly important that we get in there early and try and get these women before they become pregnant. So if we can do that, and it's definitely easier said than done, and usually involves quite a lot of collaboration with the family medicine teams, general practitioners, and hospital diabetes units, including the adolescent transition team. But what we would like to see is that this is discussed yearly at the annual diabetes review, and that women are offered safe, effective contraception until the time that they want to come off their contraception and try for a pregnancy. We would give education also about diabetes and pregnancy, and the take-home message that actually most pregnancies with diabetes are perfectly healthy and result in perfectly healthy babies, which is a different message from that we were giving a few decades ago. We'd stop unsafe medications before trying to conceive as well, particularly statins and ACE inhibitors, stop smoking and reduce the levels of alcohol if people are drinking, and start 5 milligram of folic acid. So because we know in the UK at least that more than half of pregnancies are unplanned, rather than talking about particularly planning pregnancies, which women often don't identify, we talk about whether people are on folic acid or contraception and what sort of mentality they're in. And if someone is at risk of becoming pregnant or might become pregnant, then they should be on folic acid at 5 milligram dose. And aim for an HbA1c as close as possible to 6.5%, recognising though that we need to be realistic and that not every woman will be able to achieve that before getting pregnant. So if it's a particularly unrealistic goal, we often compromise with the patient to make sure that they stay engaged and come and do the best that we can for them for their pregnancy. I also think it's really useful to think about the physiology and the changing physiology of glucose metabolism in pregnancy. If we're going to be able to treat the condition effectively, then it's important that we match the glucose and the insulin. And a lot of people don't think about the way that that changes over the course of a pregnancy when they're managing somebody with insulin-treated diabetes in pregnancy. So one thing we know from our tracer studies is that glucose absorption, or the absorption of carbohydrate into the bloodstream, doesn't change across the course of pregnancy. So you'll know from your clinical practice that someone who eats breakfast in the morning and is pregnant, their sugar shoots straight up, whether that's at the start of the pregnancy or at the end, it's the same. But what does change is after that, after the meal, the way that glucose is disposed of. So the way that glucose exits the bloodstream and is used for energy. At the start of pregnancy, that's quite quick and happens relatively easily. But in late pregnancy, it's a much more sluggish response. So again, you might know this from your clinical practice if you work with pregnant women, but those postprandial peaks last much longer at the end of pregnancy than they do at the start. And the peak isn't quite as high either, so it's a slow reduction rather than quicker at the early stages of pregnancy. Coupled with that is a change in the way that insulin works. So we know that as pregnancy progresses, the time to the peak insulin concentration is delayed. So it's a slower absorption, it's slower to rise and become fully effective. And then it hangs around longer as well, so the duration of action is longer. So what this means is that the combination of the two mean that women spend large amounts of time with abnormal glucose levels in pregnancy, particularly hyperglycemia. And despite all of our best efforts, we know that women with type 1 diabetes spend about half of the time with normal or target blood glucose levels and about half of the time with abnormal levels, so particularly hyperglycemia. It's slightly better for women with type 2 diabetes, up to sort of 60 or 70% time with target blood glucose levels, but there's still a long way to go. And that's probably the explanation that we have, that there hasn't really been any improvement over the last few decades in terms of the outcomes for these women and their babies. So there are a whole range of new technologies that we can use to help us manage these conditions, ranging from the blinded CGM to real-time CGM, the use of pumps and sensors together, sensor-augmented pump therapy, and more recently, at least in trial stages, of closed-loop insulin delivery, or the artificial pancreas. So the data in terms of the use of CGM is quite mixed in pregnancy. Until recently, we had two main studies. The first was of blinded CGM in our centre and showed a reduction in terms of HbA1c with the use of blinded CGM in pregnancy. But this was contrasted by the Danish study of real-time intermittent CGM, which found no difference in terms of glycemic control or outcomes. What was interesting here was that compliance was quite poor, so about 60% of the women used it as the team suggested they should, and that it was only intermittent anyway. So we know from trials outside of pregnancy that using CGM works if you use it at least 70% of the time, which was never the trial design in this case. Most recently, the concept study was published just a few months ago in The Lancet and showed in 215 pregnant women from 31 different centres, the largest study that we've got, that HbA1c was lowered by a modest amount, only 0.2%, not particularly huge, a slight increase in terms of time in target, so 68% rather than 61% with time in target, but there were quite significant improvements, about half the rate of large for gestational age babies, a significant reduction, again about halving of the rate of requirement for neonatal intensive care units, and a modest reduction also in terms of neonatal hypoglycemia. So while we didn't necessarily see huge changes in terms of glycemic control, it was obviously enough to have quite a significant impact in terms of the neonatal outcomes, and we're looking more closely to see why that might be. In terms of insulin pumps, again, the data is quite variable, and most of the pump studies that we have, particularly the randomized studies, are historic, so they rely on old technology, people who are less familiar with the systems, and even older insulins as well. From our own clinical practice and that around the world, we know that pump therapy is safe in pregnancy and it's effective. It treats women effectively and is able to safely control blood glucose without any obvious adverse outcome. We're confident also transitioning to women to pump while they're pregnant. So although there was some historic concern about that, there's not anymore, and particularly in centres that are used to using insulin pumps, it's quite safe to do in pregnancy. But we still don't really have randomised data to suggest that they should be routinely used. And there is some indication, potentially for reasons we don't fully understand, that women who use pumps might have bigger babies than those who don't, even if their glycemic control is better. So I've got just a couple of examples here. We could pretend that the use of continuous glucose monitoring and pump means that we have patients whose glycemic control looks like this, but that's not true, it's not honest. We have a small number of women who have traces that look like this, but this is something more like what is honest, and even that actually is pretty good and a lot better than many of our other women. So there's still a lot of room to move, and that's where we're doing our trials on the closed loop systems, the first study of which was published last year and the second should be published shortly. In the meantime, the closed loop systems unfortunately aren't available to all of us yet, and we don't know yet that they'll be effective for everybody. So we've got a couple of things that we do fairly routinely to try and improve glycemic control in the meantime. So to aim to our targets, which are less than 5.3 for fasting and less than 7.8 at 1 hour post-meal, we place quite strict attention on the diet and give really quite strict recommendations in terms of carbohydrate portions, 20 to 30 grams for breakfast, 40 to 50 for lunch, and 50 to 60 for dinner. And you'll remember from the graphs about the carbohydrate metabolism and the insulin that changes over the course of pregnancy. We also try quite hard to match that and think about the physiology when we're determining treatment. So while at the first start of pregnancy, we might recommend giving the bolus, say 15 minutes before a meal, towards the end of pregnancy, we gradually increase it by small amounts each time, up to often at the end of pregnancy, 45 minutes or even an hour before the meal. And that gives more time for the insulin to act, and also it better matches the peak then, so that the insulin peak and duration of action is more closely matched with the carbohydrate peak. So that's particularly useful for that pattern that we often see where women have a high peak and then they have a hypo before their next meal. And you can usually fix that by bringing the bolus slightly earlier in relation to the meal. The other thing that can be incredibly useful is post-meal exercise. So I was having a chat with one of your colleagues last night about the prayer during Ramadan, and those big meals after big meals after sundown can often be counteracted by quite active prayer times, because that postprandial period is so important if we're going to reduce that postprandial peak. So we often recommend that women go for a walk 15 or 20 minutes after their meal, and it reduces their postprandial glucose by about 1.5 millimoles per litre, which is actually just as effective as insulin in a lot of these cases. So are we making progress? Well, I think we are. In terms of technology, we're able to step closer towards euglycemia. So we know with injections, it's about half of the time. With target blood glucoses. With pump therapy, we can improve that a little bit, and with sensor-augmented pump particularly, possibly with closed-loop therapy even more. But we know that these things aren't enough yet, and we still need to keep working on it. We need a stronger evidence base before we can recommend the routine use of these technologies in pregnancies, but there are lots of things that we can do in the meantime to make sure that we're doing our best to improve outcomes for these women and their babies. And I look forward to hearing from you all a bit more, hopefully now, but also in the workshop, and seeing how we can work together to try and make sure that we have as many healthy mums and babies as we possibly can. Thank you.
Thank you, Dr. Zoe, for this elegant and very nice presentation. And actually, I believe the patient education is a tough part of your management.
Pardon, sorry?
The education for the patient is very tough for you.
Yes.
In this part.
Yeah.
And actually managing it with multiple co-partners like the obstetrician,
yeah,
nutritionist, I believe it's tough. Can you tell us part of it?
Yeah. So we're quite lucky, I think. So the question was about working together with the other teams and making sure that we educate patients properly. I'm actually a bit of an imposter here. I've changed teams. I used to work in diabetes, but I'm actually now an obstetrician. So I've swapped over. I'm one of the other people, but it's incredibly important, I think, as you say, to work together. So our clinics are joint clinics. Patients are seen by both the obstetricians and the diabetologists, and often together in the same room at the same time, and with an educator as well, or a dietitian. So a nurse or a dietitian can come in the room at the same time, and we can make sure that we're all giving the same messages and that we all have the same understanding of the way that diabetes affects pregnancy. We're pretty lucky working in pregnancy, I think, too, though, because women are uniquely motivated. So while it might be difficult to educate somebody who's had diabetes for 50 years and knows the way that they do things, actually, women who are pregnant, they want to do the best by their baby, so they're incredibly likely to listen, much more so, and they're motivated to do the things that you tell them to do. So it's a very rewarding area of practice, I think, as well.
Thank you for your elegant talk. I would like to ask you, what is the maximum dose of metformin which you give for your patients?
Yeah, so metformin almost always comes up as a question in this kind of talk, and I think it's a tricky topic because there's no clear answer, and we still are collecting more data. Our practice is to have a discussion with every woman and explain the evidence that's there, explain that it crosses the placenta, that it's not routinely recommended, but some women will then choose to use it. And in terms of the maximum dose, it varies across different centres, but ours is normally 2.5 grams. And we would gradually titrate it because particularly in pregnancy, the gastrointestinal effects can be quite significant. So we usually do it quite gradually, which is another reason that you might not want to use it if you had quite severe glycemic disturbance. You've got a finite time to act in pregnancy, so if it's going to take a few weeks to get up to the dose, then maybe you'd be better just with insulin.
Any questions from the floor? Okay, nutrition and the diabetic pregnant, it's tough a bit, and you mentioned some points of this part and medication giving, like folic acid and whatever. What's the main message you give to the mother?
Sorry, in terms of nutrition?
Nutrition, yeah.
So we talk, it's slightly different for women with gestational diabetes versus pre-existing. So for women with gestational diabetes, we have discussions about healthy lifestyle, making sure that they have an understanding of what sorts of carbohydrates are healthy and what sorts are not. So we don't give them strict carbohydrate counting rules, but we do show them normal portion sizes for bread and for rice, and talk about what sorts of foods might make up meals, and that particularly most women can get away with having more carbohydrate in the evening than they can in the morning. So having a very small low carbohydrate breakfast and then having more carbohydrate at night when you can tolerate it slightly more. For the women with pre-existing diabetes, all of those women are trained in terms of carbohydrate counting at our centre, so we give them those quite strict allocations and then try as hard as we can to stick to that. And we're also quite, we have quite detailed discussions actually with women often about almost the same presentation. So helping women to understand how the glucose crosses, or that glucose crosses the placenta but insulin doesn't. So every time their glucose is high, their baby will be producing insulin, and that's what causes the low blood sugar in the baby afterwards. So trying to explain some of those things to women means that they can then understand why we're telling them to do things, and hopefully they're a bit more motivated to make those changes themselves.
Actually, it's a very tough mission. Thank you for your presentation, and it was really nice.
Great.
I'm calling next Professor Pratik for his presentation. He's from UK, and he's going to speak about simple tricks in managing the type 1 diabetes.
Hi, thank you. It's lovely to be here in Cairo, and my task over the next half hour or so is to make something really complex into 4 or 5 simple rules or simple ideas that might help you when you're looking after people with type 1 diabetes. So I'd like to start off by just making a point actually that, you know, we saw about an hour ago when Dario was talking that in type 2 diabetes you have so many trials about cardiovascular outcomes and, you know, intimate details about the kind of risks and benefits of different drugs. With type 1 diabetes, what we have is the DCCT edict study, which is 30 years old. Yeah? There's very little new stuff out there, but it tells us something really important. And I don't know how the A1C here is in Egypt, but in the UK, our average A1C is about 8.5%, which means that on average, we are doing worse than the control arm of DCCT, right? On average. And I don't know how many people there are in the world. In the UK currently, and I think internationally, look at the T1D exchange, less than 20% of people manage to achieve less than 7% A1C. And that means that if you look at the bottom panel here, that means by the time these people get their diabetes when they're 20 or 30, by the time they're my age, by the time they're in their mid-40s, they have a 60% higher risk of complications than they should have. And in fact, they have a 30% higher mortality by the time they are 50. Okay? And they could do this, control arm, 30 years ago in DCCT. So what sort of things have we learned over time about what can help some people or improve the control? And one of the, as ever, it's pediatrics who shows us the way. And I don't know if any of you have come across this Vidore study, but these are a number of different units, about 18 different units across Europe. And you can see here, some units had an average A1C of 9%, and some units had an average A1C of 7.5%. So they did an evaluation about what are the key differences between these units. Is it the fact that these units here have 3 times more nurses, 3 times more pediatricians? It's not the case. The number of doctors and healthcare professionals per patient was roughly the same. Was there more deprivation or poverty in those areas? Again, not the case. The key factor that differentiated these units here to these units here was tighter targets and a uniform message. So every member, the dietitian, the doctor, the nurse, said the same thing. It's not the fact that the doctor is saying, oh, you need an A1C of 7% and you need to take 5 tests a day, and the nurse is saying, I know it's very difficult, yeah, you're doing 2, it's okay. Because the patient will always go for the easiest option. And so that's the first kind of top tip, if you like, is that with whichever environment you're working in, your whole team needs to have a common idea. And so whenever the patient has a touch point with your team, they are reinforcing those same points. Of course, we have individualized aims for a person, but in a way, I think the way this needs to be understood is that you have an individual aim where you want to get to, but you're always aware in the distance about what we want to achieve is as close to 7% as possible. And I actually don't like criteria that say you have to get an A1C of 7%. Because actually the real target is the lowest A1C possible without unacceptable hypoglycemia. And we will accept more hypoglycemia in a young person than in an old person, because hypoglycemia has very different impacts on the person. Under 10, there is impacts on the brain and you want to avoid it. Between 10 and 50, actually, the brain deals with hypoglycemia pretty well. And then beyond 50, again, the risk of hypoglycemia and hypoglycemia-associated injury is again problematic. So what are the barriers to achieving that 7%? Why can't we achieve, as a group, why can't we in our clinic achieve those things? And I think when I put it together, I thought, you know, the first thing is providing the patient who has to make decisions all the time with all the right education. Giving them the tools that they need to achieve what they want, and for them to have the confidence to use the education and tool properly. There is some skills and support. The amount of support we give to people, the more support and more light touch contact you have with people, the better they do. And at the end of it, actually, it's very hard for the patients to keep up the motivation to keep doing these tasks again and again. So if you look at patients in your clinic, there are some simple rules of thumb, and this is not evidence-based, this is my opinion, right? I'm putting this out there, but if you've got someone with an A1C above 10% who has recurrent diabetic ketoacidosis, you know, even though they tell you, if you ask them what insulin they're taking, they might tell you, I'm taking 20 units of Lantus and 10 units of Humalog 3 times a day, but they're not. If they were taking that insulin, they would not have an A1C of 10%, right? So sometimes it's better to cut the crap and say, right, your A1C is 13, 14%. I know that you're taking your basal insulin most days, but you miss it occasionally, and you're taking your rapid-acting insulin once or twice a day. If your A1C is 11 or 12%, that's what's happening, whatever the patient tells you. And in that case, if they're having DKA, DKA in that scenario is a form of self-harm. And if you've got someone who's cutting their wrists or taking paracetamol overdoses, you send them for psychological support. And that's how you need to deal with recurrent DKAs, right? People who are running A1Cs of 14%, 10, 12%, taking 1 or 2 shots a day, they're in true denial, or they hate having diabetes. And again, the response there, or the treatment there, is going to be psychological support. Education in that scenario is not going to work, because it's a completely different help. And you know, whether diabetes clinicians like you and me need to have some psychological skills is a kind of different debate. I think they should. I think that's an essential part, as important as learning how to use the pump. Then you get to the people, which is the vast majority of people who run between 9 and 10%, or 8.5 to 10.5%, and they're taking their background every day. They tell you they're taking 3 shots of quick acting a day for every meal, but if their A1C is 9 or 10%, they are eating food that is not covered by insulin, for sure. And most of these people will take their insulin first thing at night with their main meal, maybe at bedtime, but they're missing 1 or 2 meals through the day. And again, adjusting the dose is not going to work there. What you have to do is find the meal that's not covered and cover it with insulin. I call those the cruisers, because they're cruising along, they have some things, they take insulin for their main meal, they kind of average along, and they kind of tell you, diabetes doesn't rule my life, I do just about enough, I feel well, A1C is 9%, that's your problem, I feel well. Then you get down to the people who are trying hard, they're doing all their injections, they're doing 4 or 5 tests a day, but they're still running at 8%, and those are the triers, actually, and they need better tools. And you get down to the people who've got an A1C of 6.5 and 7.5%, they're doing everything fine, and when they come in your clinic, they make your day, you feel happy, you say, give them a hug, say you're fantastic. And then you get these perfectionists, and I have a bunch of these in my clinic who, they say, Doc, what's your A1C? And I'm going to beat it. And sometimes whatever you say, they won't listen, because they know what they're doing, and they can do it better than what we could do if we had diabetes. So it's a different scenario. So I don't know if that kind of helps when you see that person in clinic. A tip is work out where they are, because your interaction with that person and what advice you give will be a little bit different, whether they're a hater, a trier, a cruiser, or a perfectionist. Now the other thing is we offer different types of care. A kind of standard of care, if you like. I'm not going to talk about twice daily mixed insulin, because that in a sense becomes either an economic or a psychological issue. But let's say standard of care for type 1 diabetes is fixed multiple daily insulin. And I'd like to make a differentiation between MDI, or basal bolus treatment, and what we call flexible insulin therapy. And if you look at the first column there, I'd say even in the UK, where there is an established diabetes training program, 50% of type 1s will be on a fixed dose regime. I take 6 units 3 times a day Humalog, or 8 units 3 times a day Humalog. Less than half of the patients are trained up to talk a different language, a language of I use a 1 unit for 10 gram ratio, I split my basal insulin, I talk about insulin correction factors or insulin sensitivity factors, right? So your basic bog standard is fixed dose treatment, and with that treatment you can, it's very hard to achieve anything better than 8.5%. You're not correcting. It is substandard care, actually. You want to be getting up to this middle level where you're at least talking the language. But even that, actually, if you look at people who are doing 4 tests a day, pre-meal boluses, split basal, and I'll talk about that in a second, the average A1C in that scenario is 7.5 to 8%. If you look at patients who are achieving 7 or below, achieving those DCCD targets, if you like, where you have a very low risk of complications, they're going above and beyond that. They're doing 7 to 9 tests per day. They're bolusing for their meal. They're taking small, frequent meals. They're looking and reviewing their data. They may be adjusting for fat and protein, making adjustments for exercise, and they're looking at data and pattern recognition. And that's a little bit like, we talk about football in the UK. The first one is someone who's playing for their local team. They practice once a day and they play a little bit and they're a little bit good, right? And then you get to the Premier League, you have to practice every day. You have to work harder. You have to know more. But if you want to play in the Champions League or win the World Cup, you have to work really hard. And you have to know a lot. And I think that's the difference in the A1C that you achieve. You don't achieve perfect targets by running things easy. There's something we have to recognize, is that there is a person behind the numbers. And the person you're talking to and what's going on in their mind and their emotional state actually governs their A1C output. And these are just some data we've had published recently. And what I want to show you here is the yellow and red bars indicate people who have a high degree of diabetes distress. Now, diabetes distress means the burden that diabetes places on a person. If you look at here, if your A1C is good, 7.5%, then the level of diabetes distress is kind of 50% don't score any distress because they're doing well, and maybe the high distress is 20%. Once you get above 8.5%, and the average in this study was around about 9.5% in that group, more than 50% are scoring extremely high diabetes distress. And what we've learned is, if you're really scared and worried about your diabetes, you know you're going to the doctor, they come to see you, and they know my A1C is 9%. They know it because they're not taking their insulin, right? And they know what they're going to get. What happens if you go into the headmaster's office with not doing your homework? You get told off. And even if you approach those people in the nicest way, in their head they're thinking, this is bad, I'm a bad person, I'm not doing what I need to do, I'm finding it hard. And so all that lovely and brilliant advice you give them, they find it hard to take on board. And what we've found is acknowledging, what are you finding difficult? Talking about why you're distressed. Is it fear of hypos? Is it you're burnt out? Is it, you're depressed? Is it people are harassing you at work because you have diabetes and they don't give you time to test or time to treat your hypos? It could be any of those things, and until you address those things, that group who are running high do not improve. You can give them all the information you want to. It doesn't go in if you don't address the core reason why they're running, why they're not doing the tests and injections that they're taking. So I think the important thing here is, we've got to find the right building blocks, we've got to get the right information, and then what I'm going to talk about next is about how we get the right guesses to make sure that the insulin therapy we set up is correct. So the aim of flexible insulin therapy, because I don't like to talk about MDI, is to mimic physiology as best as possible. So what is physiology? If you take a young healthy adult, medical students, feed them 50 grams of carbohydrate 3 times a day and measure plasma insulin, this is what you get, right? And what you can notice here is, number one, the plasma insulin spike is extremely quick. In fact, the peak insulin is within 15 minutes of eating the carbohydrate. And remember, even with faster acting insulins that you have now, the peak insulin is at about 60 minutes after you eat. So if you inject just before you eat, you are 50 minutes behind the curve, right? But what we're trying to do is we're trying to fill that gap with basal, and then the idea is, of course, that we have 3 bolus doses that in some way approximate the requirement of that given time, right? Now, when we look at the split in normal healthy people who are eating a diet that's between 120 and 200 grams of carbohydrate per day, the split between basal and bolus is 50 and 50. So that's kind of the first rule, that when you look at someone's insulin therapy, work out, so when someone comes in and they say, I'm on 10 units of Nevirapid 3 times a day and 10 units of Lantus, they are 70% bolus, 25% basal, that's the problem there that you need to fix straight away. Right? The next thing is, can you kind of guess what dose they should be on? And these sort of things are quite important, I think, because knowing what the patient should be on helps you guide, well, this is what they're taking, this is what they should be on, where's the gap? Do I need to adjust the basal or the bolus? Knowing where you should expect to be, knowing the pre-test probability, helps make a better decision. So if you've got a young lady there, she's quite petite, let's call her about 55 kilos, you can predict actually that her dose, and this is based on, if you look at all the databases, her dose of total daily dose is going to be about 25 units of insulin per day, right? If she's 5'2", 55 kilos, And that means you already know that her basal insulin through the 24 hours should be about 12 to 14 units a day. And if you put her on 20 units a day and she's hypoing, then it's going to be the basal. Right? If you take middle guy, let's say that's me, I'm 80 kilos. If I had type 1 diabetes, I would be on about 40 units a day. And if you look at the databases, that's the average, BMI of 26, weight of 80 kilos, about 0.6 units per kilogram is the average that people are on, right? And if you're quite large, and again, nowadays, there's no reason why type 1 diabetes people are just as obese as the rest of the group. In fact, slightly higher BMI than the average background population in type 1. Once you cross 80 kilos, I found certainly in my practice of people on 0.8, 0.9, or even 1 unit per kilogram. And there are some people, though, who are 100 kilos but only need 50 units of insulin per day. So they're not insulin resistant because they're on 0.5 units per kilogram, right? But it's important to kind of have a feel for what you're aiming for. Now, the basal insulin, of course, is the idea of basal insulin is it's the amount of insulin that if you're not eating, you're cruising at a plane altitude, right? And the role of basal insulin, of course, as you all know, is to control hepatic glucose output. And again, it's something that patients really don't get. If I'm not eating, why is my sugar going up? Well, it's because the basal isn't enough. But of course, you don't go steady and no one day is the same. Every day has a different push and pull that goes up or down. Exercise, activity, alcohol, relaxation, sports, all these things affect the basal insulin. And so thinking that the same basal dose will work every day is a little bit of a challenge, right? So I don't know if you come across this, but in traditional teaching, we say if the sugars are not good, let's focus on the fasting glucose and let's get it right. Yeah, that's what we always do. And how many times have you done a day like this, where if you look at the fasting glucose at 6 o'clock in the morning, one day it's up here at 300 milligram per deciliter, 3 days it's low, and 2 days it's the middle. Yeah? In type 1 diabetes, by definition, you get, if you look at a week's numbers, you get 2 nights are high, 2 nights are low, a few nights okay. And so how can you adjust the basal insulin based on this sort of dosing? And actually, the reason why fasting glucose is so variable, these are data from a closed loop study done in Cambridge actually, and each of these lines denotes an individual patient, and it denotes the amount of insulin the closed loop gave, the variation night on night. So 100% here is how much insulin they were programmed to take before they went into the study. And you can see here, on some nights, they only needed 50% of that insulin. And on some nights, they needed 150 or 200% of that insulin. So our overnight insulin requirements vary from 50 to 200%. If you give the same dose every day, your fasting glucose is going to vary from hypo to hyperglycemia. So actually, I think it's quite important to tell people that the reason you're getting variable morning sugars isn't because the dose is wrong. It's because it's natural and physiological to need different insulin every day. This morning, I've slept for 3 hours, I've spent the night on a plane, I'll probably be a bit insulin resistant. So if I had type 1 diabetes, I'd have needed higher background insulin. Another night, if I'm walking 15,000 steps, I might need less. If I've had a high fat, even late evening meal, I will need more. So actually the skill for the Champions League players is to work out how to adjust the basal insulin depending on your requirements. If you've had a really active day, if you've drunk alcohol, if you're in Europe, if you've had a hypo in the day, you need to drop the overnight a little bit. If you're unwell, if you're stressed, if you've been sedentary, if you've had a high fat meal, you need more insulin through the night. So using those governs, we can, and that's one of the reasons why, certainly in our practice, we like to use split basal insulin. Because that allows you, if you've had a busy day, you can take less at night. If you've had you can alter the overnight dose day on day by 20% up or down as a rough guesstimate. And that is better than a once daily basal like Lantus or Tracebo, which you cannot adjust. So certainly, and actually if you look at the data in the UK database, people who use split daily insulin do better than people who use it once daily. Right? Now another point that comes up a lot is put your hands up if in your practice someone says if you wake up with a high morning glucose, it is because you might have had a nighttime hypo. Anyone say that? Not in your clinic, but in your clinic, yeah? Anybody else? Yeah? Yeah. Only in the books, as the lady says. I just want to highlight this because I think it's very widespread, and certainly nursing colleagues do it a lot. If you've got a high morning reading, the most common reading is that you've been high through the night, and the most common cause of that is a high fat meal in the evening. Okay? About 15% of people with type 1 diabetes have a dawn phenomenon where the glucose will be in range at night but rise early on in the morning. Now, the Somogyi effect or rebound hyperglycemia supposes that you've had a low in the night and you wake up high. And there's about 20 papers in the literature from 1980 that have failed to find this happening even once. Okay? This was first described in 1936 and never again. But so many people talk about this and it stops people from adjusting insulin appropriately. Right? And we looked at continuous glucose monitoring traces, and actually the most important message is if you wake up with a glucose below 5, below 90, there is a 90% chance that your patient was hypoglycemic through the night. Morning glucose is the best predictor of overnight hypo. If you wake up high, you've been high through the night. If you wake up low, you've been low through the night. And you don't want to be, if you wake up with a glucose less than 90, there is a 90% chance that you've been hypo through the night. Here in Egypt, are we millimoles or milligrams? Milligrams, okay. I have to mentally convert each time. So I think tip 2 is think of the total daily dose and guesstimate and make sure that the dose of basal insulin is about 50% of that. Understand the variation in basal insulin requirements, and if your patient is willing and capable, I'd split the basal to allow to and teach them how to adjust on the basis of that. So now how do we optimize the bolus treatment? So I go through this in a lot of consultations, actually, saying every time you do a quick acting shot of insulin, there's a very simple mathematical formula that governs the correct dose. And that formula is food insulin plus correction insulin minus insulin on board, right? So the food insulin is carbohydrate content divided by insulin to carb ratio. The correction insulin is current glucose minus your target glucose divided by the sensitivity factor minus insulin on board, right? Now, if your last injection was more than 4 hours ago, insulin on board is 0. So you can forget that. So, if you've had some pasta and it is 65 grams of carbohydrate, then 65 by 10, if 10 is your insulin to carb ratio, 6.5 for the food. If your glucose is 200 and your target is 100, and your sensitivity is 50, 2 units correction, so your total dose is 8.5, right? Does it make sense? And actually, people are given a dose, take 10 units, but they don't quite know what that really means. And I think it's quite important to judge that if you're not eating any carbohydrate, then your food insulin becomes 0, but there is still a need to do a correction dose if your sugar is not perfect. Every time, if your sugar is a lot of people won't inject if their sugar is 5, or if sugar is 100, 120, because they're scared of going hypo. Because the sugar's good, why should I take insulin? And so understanding that the food, every dose of insulin is a combination of a food insulin and a correction insulin is quite important for people to convince them that they do need to inject. If you're having a small snack, a small sandwich, it's only a sandwich. That's 40 grams of carbohydrate, that's 4 units of insulin. Without that, your glucose is going to go up by 120. If you don't inject for that. So I draw this out and I say to people that actually that mathematics is about high school mathematics, number 1, right? So if you've done high school, you can do that maths, but asking someone to do that maths 5 times a day for the rest of their life is quite a tough ask. And I came across a statistic recently, that there are more people connected to the internet with smartphones than have running water. This is what technology is supposed to do, right? Do the maths for you and govern your dose. And we'll talk about that this afternoon. Now, when you're using the bolus, there are 2 rules that are in the literature actually. One's called the 500-100 rule, right? And if you're using milligrams, that becomes 1800. So if your total daily dose is 40, then your insulin to carb ratio should be 12 according to some rules. Now, I must admit, I don't like the 500 rule, and the counter opinion is that your insulin to carb ratio should be 350 divided by total daily dose. So if you remember that young girl who was on 25 units a day, 350 divided by 25 will give you round about 15. So her insulin to carb ratio should be 15. If it's me with a total daily dose of 40, my insulin to carb ratio should be 350 by 40, which is 9. And if you've got the big guy who's 100 kilos on 80 units a day, his insulin to carb ratio should be 6. Does that make sense? And that gives you a guidance of what your expected insulin to carb ratio should be in different people. Measure their total daily dose and do 350 divided by total daily dose, and you'll get a very good guess of what their carb. So if you don't know what to do, you look at the data and it's all over the place. That gives you a really good guide of what you should be looking at. The same thing for correction factor. 100 gives you 80 in milligrams, it becomes 1800. But for again, somewhere between 1800 to 2000 is your right dose. So if you're on 50 units a day and you only use 2000, that gives you a correction factor of 4. Okay, 2000 divided by the total daily dose. The next thing is, if you are using apps and technology to guide what the target is, a key factor in units that have a lower A1C is that they program their pumps or their meters or their apps to aim for a glucose of 5 to 6 millimoles per liter, 90 to 100 milligram per deciliter. And that means that if you've got a reading of 150, in normal course your patient will never correct at 150. But if you use an app that tells them to, it's 1 unit correction that they're missing. And if you add that up over the month, that is 20 units of missed insulin. That is 0.5% of A1C that they've lost because they've not corrected using a machine. So as I said, a robot is someone who can do these mechanical tasks again and again, and that's where we need to use the technology, and I'll talk about that this afternoon. Another place where you find what I call A1C for free is in your consultations. How often do you emphasize the timing of insulin? I just showed you the slide that said that if you inject just before you eat, you're already 50 minutes behind the game. And these are the data showing that if you bolus just before the meal or after the meal, your average rise is at least 100, and actually it's probably closer to 150 or 200 post-meal rise if you inject immediately pre-meal or just post-meal. If you can inject 15 to 20 minutes pre-meal, your average rise is 80 to 90 milligram per deciliter. And if you draw that out to patients automatically, you say, you know, of the meals, if you take 3-4 shots a day for a week, that is about 28 shots or 30 shots a week. If even half of those you can take 20 minutes pre-meal, your A1C will drop by 0.3, 0.4%. And the last thing I think again is important here in terms of bolus is understanding the impact of high-fat meals. Because certainly, you know, when you're having rich meals, particularly evening meals, they tend to have a lot of fat. And if you look at this is the closed loop data, this is a low-fat meal, and this is a high-fat meal. And what you can see here is that the 1-2 hour glucose is not different. Fat does not affect the carbohydrate peak of glucose. What it does do is keep the glucose up for 4 hours later. Right? And if you use a closed loop, the closed loop gives you 42% more insulin in that later period. So if you've got a pump, you can use fancy dual-way boluses to cover that post-meal. But if you've not, then what you know is if you've had a high-fat meal, then at 2 hours later, you're needing 20% or 30% more insulin as a second quick-acting bolus to cover it. Right? And so that's again important. If you don't do that, you're going to wake up high. So a common theme when people have hypoglycemia is also, so it's important to recognize this theme, that if you have an inadequate bolus, so let's say someone hypos, and so they are scared of bolusing, so you reduce, or they reduce their bolus, they're going to have a high reading. When they get a high reading, that makes them do more corrections. When you do corrections, which is insulin without food, you have more hypoglycemia, which you treat and you end up high. And most of the people, if you have, people complain of high variability, the cause of high variability is inadequate bolusing and a dissociation in time of bolus and food. So now the person is injecting here, eating here, injecting here, and eating here. And if you've got high variability, it's diagnostic of someone who's got that pattern. And the way to beat that is you've got to be aggressive with your bolus and soft with your correction. If you're aggressive with the bolus, you don't have so many highs, you don't do so many corrections. And a lot of people think, hang on, if I'm increasing my bolus, I'm taking more insulin, I'm going to gain weight. But you're not taking more insulin, because if you take less for your bolus, you're going to end up taking more in correction. You're just redistributing insulin around. So tip 3 is understand the maths behind the bolus and find a way to explain that to your patients. The importance of timing of injection. It's what I call A1C for free. No extra work from the patient. Maximize the work they're doing. If you delay the bolus, if you bolus after you eat, you are going to run into problems with more hypoglycemia. And as a rule of thumb, go aggressive bolus, soft correction. The next tip is on testing, and these data are quite important. On the left you've got the type 1 diabetes exchange here, and on the right you've got the German diabetes registry. And I want you to see both of these data are similar. If you're doing 2 measurements a day, 2 to 3 tests a day, your average A1C is going to be 2 to 3 tests a day buys you an A1C of 8.5% to 9%, right? That's what we said in the first slide. Most people who run 8.9%, they test. If you ask them, they say I test 4 times a day, but their meter download will say 2.6, because they do 4 times a day half the time, but then they have a few days when they only do 2. So in their head, they think they're doing 4 a day. If you look at what people who are achieving an A1C of 7% do, they're doing 7% here. They're doing 7 to 8 measurements per day on average. So if your patient gets 7% without hypos, they're very, very lucky. Right? Most people have to work that hard. And I think it's important, people with diabetes, if you give them 3 strips a day and then say get to 7%, that's a bit like giving someone a one-legged, a flat tire and saying you've got to go fast. Now, to achieve 7%, we looked in our clinic on the meter download. And these are all people doing at least 4 tests a day. And we looked at the data to see how many of those readings were between 80 and 180. Right? And actually, if you're achieving an A1C of 7%, only 60% of the readings were between 80 and 180. Right? So I asked the patients, well, we're aiming for 7%. How many of your readings do you think you need to get between 80 and 180? And almost all the patients think that they need to get 90% of their readings within range. And so whenever they get, the reason they don't measure is because why do you want to see a reading that is 220 and fail? Because you want the numbers to be tight. But it's important to tell them that actually you have to look for those readings and correct them, and it's okay, I think, to have 25-30% readings between 180 and 250, because that happens anyway. And the way we explain it in our clinic is that every time you take a bolus of quick-acting insulin, it's a bit like hitting a golf ball, and that flag in the corner there you can see, that flag is the perfect glucose of 100. Now, even if you're the best golf player, you're not going to hit the ball in the hole every time. 30% of the time, you're going to hit it short, and you're going to need a second shot to get it in the hole. 10% of the time, you're going to hit it into the sand, a hypo, and there's going to be a problem, right? But you need to measure, because even if you've got an A1C of 7%, you've got a 35 to 40% chance that your reading is going to be wrong at 4 hours down the line. And you need to measure and check and pull it back. And that's what people need to do if they want to get A1Cs that will stop them having dialysis and eye problems and foot problems. We explain it sometimes in this way, that if you take a bolus, if you bolus post-meal, this is what's going to happen. If you bolus pre-meal, this is what's going to happen. Immediately, that's where you're finding better control, right? But 20% of the time, particularly if you have a high-fat meal, you're going to stay up. 10% of the time, particularly if you've done exercise activity or over-bolus, under-ate, misjudge your carbohydrates, you might have a hypo, right? So be careful where you are at about 2 to 3 hours later. If you have the ability, or if you've done a high-fat meal, or if you've done exercise, it might be worth checking where you are, because those are the times when you're more likely to be out of range. That's when you get value for blood. If you're stabbing yourself and drawing blood, that's got to have value. It's got to yield a action point that you're doing. What can be achieved if you use these things? These are traces from one of my patients who runs an A1C that's lower than mine. I have a pancreas, she doesn't. And she has more time in range than I do, actually. So when people work really hard, they can achieve fantastic results. But the way these super patients do them, I call them super patients, is they do micro corrections and micro boluses. They do 8 to 10 small corrections a day. And they have 5 grams of carb here, 10 grams of carb there, never eat more than 35 grams, always pre-bolus. If you're looking, what do you need to do to get under 6.5%? You need to limit your carbs to 30 grams per time, maybe have 3 or 4 small meals, do 8 to 10 boluses a day, catch the post meals, do micro corrections. You see it drifting up, you take a tiny dose. That's for the 5% perfectionists who want to go perfect. So I hope I've given you a few key tips. The first one is, in your team, have a common theme. And the sort of rules that I talked about. In our clinic, we have a very strong ethos that everyone will talk about. We're looking for 50-50 basal bolus split. We're looking for split basal with adjustment of basal for exercise and fat. We're looking for bolusing pre-meal. We're looking for an insulin to carb ratio of 350 by total daily dose and a sensitivity of 120 by total daily dose. And those are common themes that the patient keeps hearing and adhere to. And those things, those are the easy wins. Looking at the data and adjusting things is the more complex thing, but those basic tools get you half the way there. Thank you.
Many thanks for your energized presentation. Any question from the floor?
Yep.
Some patients ask, when I forget to take a bolus before meal, what to do?
What to
Thank
do?
you.
Yeah, so that's really tricky actually. I think, so if you're within 20 minutes of your meal, you're best off injecting for the food, right? And you acknowledge that you're going to have a high spike and a slightly increased risk of hypoglycemia, but probably at that point, you're best off adjusting for the food. Now the trouble is, if you don't have a BG value, you can only do the food part of the bolus, right? A normal bolus is food bolus plus correction bolus, right? So if you're injecting post-meal, within 20 or 30 minutes, you're best off at least doing the food injection and then recognizing that a couple of hours later you may need to do a correction. Okay? If you're more than an hour after, you should do your measurement and then your food is 0 and you do a correction bolus. Because by 1 hour, you've hit the peak. Right? And so now, but between 0 and 1 hour, you're still going up. So blood glucose done between 0 and 1 hour, it's a difficult one to use as your correction dose because it's going up because of the food. So I'd say if you're within 1 hour of your meal after, just do the food injection and then 3 or 4 hours later you know that you're probably going to need a correction. But if you're after 1 hour, do your test, see where you are and do a correction dose. Because yeah, that's what I would do. Alogs, yeah?
Does it really help under short acting? It's work in few minutes. The patient has to take it just before meal or 2 minutes before meal.
So yeah, so the commonest, so if you're talking about Novorapid, Humalog and Apidra, these three, in my clinic I call it Novo Sluggish, Humo Slug, because they don't work in 2 minutes. They take 20 minutes to work, right? They may, if you measure plasma insulin, in 2 to 5 minutes you might see a few molecules coming into your plasma insulin. But if you look at, so we've just published a paper last week on, we reviewed all the data on optimal timing of prandial insulin. And so if you look at Novorapid, Novo Sluggish, Humoslug or Apidra, you see some insulin appearing at 2 to 5 minutes, but it doesn't really have a lot of effect. You see the peak plasma insulin concentration at 60 minutes, compared to in me, it's at 10 minutes. And that's peak plasma insulin, and the companies use plasma insulin rather than glucose lowering effect, because the glucose lowering effect, the pharmacodynamics, is another 15 minutes later, right? So these insulins they're faster than Actrapid, but they still need to be given 20 minutes per meal.
I want to ask also about the premixed insulin.
Premix, yeah?
The patient with premixed insulin can take insulin Actrapid or Novorapid or Apidra with it.
So I didn't catch the last bit, so...
Patient who is taking premixed insulin.
Yeah.
Can take...
Thank you.
patient who is taking premixed insulin can take with it act rapid or novorapid in the same day?
At time of meal.
Yeah,
Yeah. So again, the peak part of the mix, it depends whether you're using mixed-tard, in which case it's act rapid, a soluble insulin, which will have at least a 30-minute start time. So those mixes need to be taken 30 minutes pre-meal.
Yeah.
If you're using an analog mix, it would be 15 minutes pre-meal, is the way I do it, right? For your main meals. And then in between, a lot of times what people do is lunchtime, the lunchtime peak of the Instatard doesn't really cover a meal, right? And particularly when you've got high carbohydrate meals, as we have in this part of the world, often do you use 50-50 mixes rather than 30-70 mixes?
Yes,
and there is some data about using 50-50s. And if you're doing that, you need it's a tough way to do it, because you take a premix and then maybe in the middle you need to do a bit of quick acting on top, and then you've got the premix later on. It's challenging.
Dr. Rafat.
It is rather a comment as regards the use of metformin and alpha-glucosidase inhibitor in obese patients with type 1 diabetes, just to minimize the body weight and lessen the dose.
Yeah, so the question was, if I understand correctly, about what the evidence is for metformin and alpha-glucosidase. So there's a recent big trial of metformin in type 1 diabetes, of course, that showed a slight reduction in dose. The impact on body weight is, I mean, we've got to be realistic here about what the impact of body weight is, and it's in the region of 1 kilo, 1.5 kilo, if you'd get a really good impact. So my opinion is, if I've got someone who, I look at two things. I look at a BMI over 30, and I look at a total insulin dose of more than 0.7 units per kilogram. Because to my mind, 0.7 units per kilogram, irrespective of the weight, is telling me this person's got insulin resistance. And in that scenario, I don't know, my personal opinion is, if they've got an element of type 2 diabetes, and we think metformin is good for type 2, then for cardiovascular and cancer benefits, then I don't see why my overweight double diabetes patient with type 1 and type 2 should not benefit from their metformin. But I'm very realistic in the consultations about the impact on glucose, and I would often tell them, look, I don't really expect this to have a huge impact on glucose or your insulin doses, but I think it's good for your overall general health. And that would be my opinion. With glucosidase inhibitors, it's probably similar. There's very little evidence base for that, I think, in the large trial literature.
As regards the use of short-acting insulin analogs like Lispro and Aspart and Glucosilin, I found that some of them have ultra short action and some of them have very rapid action, like Apedra. Apedra, we can give it after meal and have very short duration of action rather than the Novorapid and the Humalog.
So it's interesting, and when Sanofi marketed Apedra, they marketed it saying that it was faster than the others. The real data is, if there are differences, they are very little, and I certainly would not use any of those drugs post-meal. I think it is, so I respectfully differ from that. I really strongly believe that all analogs, the three that we have here, even Fiasp, which is I don't know if that's available here in Egypt, but it is fast-acting Aspart. So it's the latest one Novo launched, not Aspart, but fast-acting Aspart. The peak is, instead of 60, is at 55 or 50 minutes. It's still not 10 minutes, which is what it needs to be for rapid acting, for post-meal injection. So I think post-meal injection, your post-meal spike is going to be much higher on post-meal whenever you look at it. So, yeah.
Any other questions from the floor?
Thank you for elegant talk. I have two questions. The first one about the calculation of protein and fat.
Yep.
Usually we have a carb insulin ratio What about protein and fat? I think the new guidelines will take in the consideration about the protein and fat, because many of the doctors say to the diabetic patient, you can eat protein as you like, and this is wrong. The second question about the use of degludec in children with type 1 diabetes. What's your experience about it?
Okay.
Thank you.
So I didn't really spend a lot of time on the fat and protein story, and there are 2 or 3 different ways of calculating the protein ratio. In the Polish way, Eva Pankowska and Olga Cordonori developed a thing called fat protein units, which is every 100 calories from fat and protein is equal to 1 carb portion. I must admit, I find that quite difficult to calculate because those information are not available. Carmel Smart is a dietitian from Australia, and she's done some fantastic work. And they're developing an app that tells people how to do this. I think for now, the key information is that for the last how many years, we used to tell people that fat slows the absorption of carbohydrate. The evidence, I've shown you 2 papers today, and there's a whole bunch of other papers, show that's not the case. Whatever the fat content, what fat does is it keeps your sugar up for longer, both fat and protein. And so the requirement for insulin is between 2 and 6 hours post-meal. So if you're on injections, roughly for a high-fat, high-protein meal, you need a 20 to 30% of whatever bolus you took for your carbohydrate as an extra bolus 2 hours post-meal. So if you're on injections and you had 80 grams of rice with a curry with a lot of fat in it, then you're going to take your 8 units for the rice, and roughly you're going to need 3 to 4 units 2 hours later to cover the fat spike. Okay? We've still not, I think there's nothing more tight than that except the recognition that you stay high. The second question was about degludec in kids, and I think, the degludec data, because it has less day-on-day variability, it has a slightly lower hypo risk. They've had the switch trial, which shows in hypo-unaware people, high-risk people, there was lower hyperglycemia. I think it works. In my opinion, still I would prefer a split basal, because actually day-on-day, particularly in young kids, if your kid has had sport and running around, that night they need less insulin. If your kid has had a day watching television, that night they need a little bit more insulin. Now the question is your parent intelligent enough to make that decision? If they are, they should be on a split basal. If they're not, they should be on degludec or Toujeo. That's my opinion.
One small question about using pre-mixed insulin in type 1. Do you use it? Because of this fat content and the protraction of the postprandial post-fat state? Most of the people, you think?
We don't use it. Well, I'd say about 10% of our, maybe not 10%, maybe 3 to 4% of our patients on premix, and the people on premix are the people who won't take, if you put someone on basal bolus, but actually they're only taking 1 shot of quick acting in the day, that they're prescribed 3, and if they're over 12%, then premixed gets you better than a basal bolus that the patient doesn't take, right? Once you get down below 10% of basal bolus is better. And complex hybrid things where you're taking quick acting for breakfast, quick acting for lunch, and premix for dinner, it's complicated. I tend not to use it, but yeah, it's an interesting thought.
Many thanks. It's interesting, and I believe it can be non-end questions. But actually, we have to close for the prayers and coffee break. Many thanks for your presentation. And actually, there is a tip number 5, which you didn't say, but it's about the safe flights. The flight which was basal with no turbulence. It was the British Airways, I believe. So it was a nice flight. Thank you all. Meet by 1, inshallah.
Thank you.